Full Metal Jacket. Okay, this is not just the title of a very famous movie. Full Metal Jacket was also the definition that's been given when you implant a lot of stent, more than 60 millimeters of stent in the coronary arteries. So in keeping with this concept, they just extrapolated this definition into the pediatric population. So therefore, I just considered patients with, in which there were more than 30 millimeters in an infant and more than 30 in a child. So what was the patient population I'm referring to now? This is the patient population we published in 2009 is a 12 years experience with pulmonary atresia patients. And we are following the Frank Heinle protocol, as a matter of fact. And we had 90 patients. And so just to show you just the diagram that is the same as you have seen before in our patient. So we have patients with, in which there are hypoplastic but confluent and dominant pulmonary arteries, the smaller group, and patients in which, therefore, in other words, patients with the pulmonary artery are worth to be shunted, in which the flow can be increased. And patients in which the pulmonary arteries are either absent or so diminutive, therefore dominant MAPCAS. Okay, so in the first group, the patient have a shunt. Initially, in this first series, particularly was a central shunt, an outflow tract reconstruction. Now, after 2009, we stent the ductus or we implant a stent. If there is an anatomic continuity between the pulmonary trunk and the ventricle, we implant a stent, the outflow tract with a hybrid procedure, even though our surgeon is not so happy with this kind of approach. Anyhow, and then the patient have unifocalization and deciding that the unifocalization, and then the VST is closed with the flow study. Our flow study is slightly different from that of Frank Heinle because we accept a pressure of 30 millimeters of mercury instead of 25, with a flow rate of 2.5 liters instead of 3 liters, but doesn't matter. So I try to make it short, the story. The overall, when the patient reaches the VST can be closed, we have a 13% mortality in the more favorable group and a 23% mortality in the worst group with an overall mortality of 21%. But the purpose of this talk is not to discuss whether this strategy is better or worse than the Melbourne strategy or whatever strategy. I'm here to talk about the pulmonary arteries. And therefore, I will skip the slides on the mortality and the need to change, to substitute the conduit. I'll show that we have a very high early morbidity of the pulmonary arteries. And this morbidity especially is, the pulmonary arteries need intervention, especially in the first 2 years, but also in significant source in the first 4 years, but also later on, they need to be treated. And it's very important to have a routine, aggressive intervention on the pulmonary arterial tree that is necessary to stabilize the result of the unifocalization. And further, it's very important, it's a great advantage of a timely interventional procedure. So this is the possible differences of pulmonary stenosis. We all know this diagram. But why do we talk about intervention? Because surgical treatment may lead to further distortion, and transcatheter intervention, transcatheter treatment is now widely accepted. But what kind of treatment? Simple balloon angioplasty by itself, yes, of course, we all do that, but it's not high, with high success, and usually this is just a palliation to buy time. High pressure balloons or cutting balloons have a higher success rate, but before or late, the vast majority of these patients are stented. And so that's why we are talking about full metal jacket. So for example, this patient has a left pulmonary artery obstruction, but also a right pulmonary artery obstruction. So in this case, we started implanting a right stent. Then, okay, and then a left stent. In this case, since the two structures were far apart, we didn't need the kissing balloon technique. So the final result was okay. But there are other cases in which the pulmonary arteries are smallish, they're all hypoplastic, and therefore they need to be treated practically simultaneously. So you insert one wire, then a second wire. But when you want to proceed with this, it's just a partial result, but when you want to proceed with implanting the second stent, then you need the kissing balloon, because otherwise the two stents are going to interfere with each other. And we see that the final result is definitely better than what we had before. But there are cases in which you need to implant a lot of stents. And for instance, in this patient who was older than 4 years, we already had implanted 2 stents on the left pulmonary artery, but later on she acquired obstructions also on the right pulmonary artery. So in this case, when you have to implant multiple stents, it's very important just to make very careful measurements, because the stents have to be implanted in a very precise position. What have you seen? But we not just hypoplastic right pulmonary artery, but also the branches of the pulmonary artery were stenotic. Therefore, we need 2 additional stents. So this patient eventually got 5 stents in the pulmonary arteries. So this patient need continuous and meticulous assessment just as a maintenance of the procedures. So what happens once we have done, we implanted stents, etc.? What happens? Then these stents, you have a high incidence of in-stent stenosis, and that's exactly what happened even in our case. So overall, in the last years, we implanted 39 stents in 30 patients, 10 on the right, 14 on the left, side bilateral, but we got 10 interstent stenosis, 4 fractured, mainly on the right pulmonary artery. 1 we had restenting, 1 we had to treat in a hybrid way, but we had no death. But what is the final result? What was the benefit that we get? And Frank Hanley showed that in his cases, when he does a conduit replacement, the pressure in the right ventricle and the pulmonary artery remains low, and this is exactly what we found as well. The pressure in our patient has remained low over time, showing that the pulmonary arteries, the pulmonary artery vascular grow in accordance with the somatic growth. Okay, so this procedure is effective even over time. So in conclusion, we in our place, the transcatheter treatment is a safe approach for infant and children with apoplastic and stenotic pulmonary irrespective of irrespective of genetic syndromes is probably a bit bit too much, because in reality, patients with DiGeorge syndrome have a worse outcome. But globally, the outcome is okay anyhow. And during intermediate and long-term follow-up, mortality and surgical interventions are rare, and the procedure is hemodynamic effective, and most patients remain asymptomatic. And the last slide is to remind you that next year, in 2016, the APC meeting will be held in Rome, and for all you are invited. Thank you very much.